Good morning, everybody. Happy Thursday. Welcome to yet another VMR. It's early in everybody's day compared to what it usually it is. And here on the west coast of the US, it's 6 a.m. And so I owe a great deal of gratitude to my co-discussant for showing up early. But before I tell you about my co-discussant, I wanted to emphasize that today is an all CP Solvers Academy day where everyone who's involved in this production, who I will introduce, is a CP Solvers Academy member. I think that I'm realizing that we have a lot of new people who join us, or people on YouTube who don't see the chat and whatnot, who may not be familiar with what the Academy is. But fundamentally, what the Academy is a group of people who are super interested in this and interested to it on another level, and get invited and recruited to be part of the team. And I'll leave it at that, to say that if you're interested at all, you find passion in this space, and you think you would have something to gain for yourself and something to give to the community, we really encourage you to join us, as many people are here live, and also to present your cases. We're looking to build a very strong community of like-minded people who are nothing but love towards each other and towards medicine. And so if you're inclined, the way to do it is to come here, hang out as much as you can, turn your video on, because that's what community building is about. And if you're able to, please present some cases. We get to know you better, and we hopefully get to hang out with you intimately as part of the Academy. Um, and the Academy is on display today with the return of VJ to the case presenter slot, with I, who is one of our newest team members, scribing, and with Julia, who you probably heard doing teaching points yesterday, doing them again today. The warmest of those seats is occupied by Mukund, who is our co-discussant today. And he's one of the very few people in the CP Solvers Academy who I get to work with in real life as well, and actually got to hang out with him in the ER last Thursday. And I got to see the intellectual might of a burgeoning diagnostic guru merged with a tremendous amount of humility and kindness that permeates through him, so much so that I have yet to tell him. So much so that he actually, the next day we worked together, couldn't help but cook up a storm for me to consume. And boy, did I consume it. Mukund, I will officially tell you that yeah, I don't even know what words to describe, apart from my only regret is how quickly the art of consuming your food was done. Thank you so much for all that you do in CP Solvers, for the joy of hanging out with you in person, and the gift of nourishment. And hopefully we can nourish each other today with a really cool case from VJ. I'll hand the mic to you to say a quick hello. And after that, we'll jump into VJ's case.
Yeah, thanks for the super warm welcome. I'm really happy to be here. It's early, but I'm excited, a little nervous. The CP Solvers has been one of my favorite spaces through med school. I'm approaching the end now in my final year at UCSF. Very grateful for all of you. I think I would have been a very different person if I hadn't locked into joining the CP Solvers so many years ago. Looking forward to that.
You and I both, my friend. VJ, you want to say a quick hello before you bamboozle us yet again?
Hello everyone, this is Vijay. I'm a pulmonary critical care resident from India. Happy to present the case back, which is basically a reflection of some of the cases we have had in the academy and presented previously.
Amazing, wonderful. Well, before you get started, maybe we can hear a quick hello from A and a quick hello from Julia before we jump in.
Hi everyone, I'm A. I'm from VMR, and I will be just applying residency here in the United States. Yeah. Thanks for joining today.
Yeah, my name is Julia. I'm from Germany, so I'm lucky. It's 3 p.m. in the afternoon, as you can see in the background. I'm full of energy. I'm very excited for the case today. Thank you so much for preparing it, VJ.
Thank you all. All right, VJ, let's rock and roll.
Okay, so I'm presenting a It is a 30-year-old lady who comes with bilateral lower limb pain and headache. So coming to the history of presenting illness, she initially developed this bilateral lower limb pain, which was gradually progressive. Initially, she was able to walk about 500 to 1,000 meters without any difficulty. Gradually, over the period of 3 months, patient has had difficulty in walking, and she says some amount of calf pain she develops, and currently she's able to walk only 100 meters. Subsequently, she also developed simultaneous headaches. A headache is diffuse, dull aching with no significant aggravating or relieving factors. No nausea, vomiting, or photophobia or phonophobia associated with the headaches. Third thing, she also complains of blurring of vision. So this blurring of vision, she says it is for distant objects. However, she's able to perceive color well. There is no history of any diplopia. There is no pain during movements of the eyes. And this has been almost non-progressive. It is there for about 2 to 3 months. There is no history of review system. There's no history of fever, skin lesions, joint pains, any pet exposures, anything of that sort. I'll stop at this.
Wow, this is very intriguing beginning to a case, Vijay. Thank you so much. Mukund, I think as is true when we take care of patients together, and you've seen a glimpse of it, and hopefully much more soon in the triage room, part of the difficulty when you're hearing 3 separate things is knowing where you're going to begin your investigations or queries. And so I'm curious, it's a difficult task, probably the hardest one, to sort of articulate where your instinct is going about where you're starting to begin your analysis. So you have the option of the legs, the head, or the eyes. Where is your mind naturally gravitating to start your thinking?
Yeah, I have a lot of thoughts, and I think this is a really interesting case to start out with these 3 chief complaints, because each of them comes with a really beautiful schema. And I think the instinct I've developed over the course of CP Solver's time is coming up with a schema for each of these complaints and then focusing in on the one that appears to be the narrowest to start.
Excellent.
In this case, I think we have a complaint of claudication. Julia has adeptly specified in the scribing box this pain, a cramping pain in the calf that this patient gets with walking is classified as claudication classically, which can either be a vascular cause, hypoperfusive cause, or you can have neurogenic claudication in which spinal cord compression mimics the symptoms of a vascular etiology. Then you have headache, which I think if it came with more specific features, I would consider to be a more high-yield diagnosis case at this point. But given the non-specificity of the headaches, we can go through the primary versus secondary headache schema at some point, but I think I'm kind of keeping this in the back of my mind for now. And the same is true of the blurry vision. There are points of overlap between headache and blurry vision. Of course, I think you can think of her blurry vision as being intra or extracranial, having to do with the brain, having to do with the eyes and its various compartments, or with the muscles such as the ciliary body and whatnot involved with the process of focusing, distance versus close, what have you. I think, I'm throwing out a variety of thoughts, but all as to say the claudication seems to be the most interesting right now.
Yeah, I completely agree with you. I think claudication is the most specific finding here. And then that's where my mind is gravitated towards. And I think the label of claudication is one that is always done with a little bit of a leap, right? Because what you're trying to establish is the patient hurts when she moves and then it resolves when she rests. And I think that has such a powerful filter to apply, which is to ask what structures really are dynamic in relation to movement. And I think that's where musculoskeletal etiologies diminish, because they should continue to hurt even when if you have a tendon or a broken bone or something. There's no reason that should completely abate when the patient rests. And so I think the confidence of a diagnosis of claudication or a label of claudication rests between the delta between how much exertional symptoms the patient is having and then how much they vanish when she rests. And if they literally go to zero, you can call this claudication. If you establish that they actually get better, but they don't go to zero, then I think you're up to consider bursal conditions or other MSK etiologies. But you're right. If you go from 0 to 100, then back to 0 with exertion, you're likely dealing with relative ischemia to that area, or you're dealing with the fact that the cauda equina is dynamically compressed by a tight canal. And so if we try to take that leap together, that this is in fact claudication, which we'll probably put in pencil, not in pen, until we really walk the patient. How do you go about distinguishing the lesion being vascular versus neurogenic? And what do you think the lesion might be here?
Yeah, I think a couple of things come to mind. One being the rapidity with which your symptoms resolve in the case of vascular versus neurogenic claudication. With, the pain in the case of vascular claudication being caused by the buildup of lactic acid. It's a process that takes time to build up. It's also a process that takes time for blood, when circulation is restored, for that lactic acid to wash away. So I would expect vascular claudication to resolve over the course of, 30 seconds to several minutes, and neurogenic claudication to resolve much more quickly as the kind of positional component to the spinal cord compression is removed. I think in particular, other positional things will really help you determine whether it's neurogenic or not, classically leaning over, decompressing the spinal canal, helping with neurogenic claudication. And then I think finally we can think about the risk factors this patient has at play. A young woman with no past medical history that we know of yet is pretty unlikely to be a vasculopath and to have developed over many years the arterial calcifications required to induce a state of vascular claudication.
Yeah, I think that's absolutely superb. When we think of neurogenic claudication, what we're invoking is a chronic form of cauda equina. Cauda equina essentially is when there's acute compression of the bundle of nerves that are in the lumbosacral spine, and acute diseases like herniated discs or epidural abscesses cause dramatic weakness. But essentially, when a patient has stenosis of the spinal canal, a slowly progressive disease process, we catch them in a phase where they haven't developed continuous symptoms, but they develop a dynamic pain syndrome. And that dynamic pain syndrome evolves very, very slowly, and if not surgically repaired, eventually will result in symptoms equivalent to cauda equina. So essentially, when we're talking about neurogenic claudication, we're talking about slowly progressive cauda equina physiology. And what helps us distinguish that from vascular claudication is exactly what you said, in terms of timing and position. How I go about it in real life is it's very, very easy to assess for vascular hypotheses with your physical exam. And if a patient has a palpable pulse and claudication, they probably have neurogenic claudication. So your ability to detect the vascular hypotheses with your fingers or your Doppler is very, very high. And that can help you emphasize or de-emphasize neurogenic claudication depending on what you find. That's sort of the realistic right there and there. You're sitting down, the patient's reporting those symptoms, put your hand on the pulses, and if they're bounding, you're like, what's going up in the spinal cord? And if they're absent, you're like, what's going on in the vessel? So you have an inlet to the vascular hypothesis from a practical perspective. However, as you pointed out, in older adults, these two conditions can easily coexist and camouflage each other. And so spinal stenosis is an age-related condition, as is peripheral arterial disease from atherosclerosis. So then you need more tools than just, the patient has less pulses, because they could have the other disease too. And so I think asking the patient to stand up and seeing if the pain is exacerbated with extension. And the idea is extension really compresses the lumbosacral spine and causes pain. So those are the two simple things I do, but I will tell you there's one powerful clue in the location of the claudication, with the vast majority of patients with neurogenic claudication reporting buttock and hip pain rather than pain in the distal calf. It is very possible for buttock and hip pain to be a manifestation of PAD, and it's often a manifestation of severe form of PAD where the occlusion is actually in the aorta and the iliac, called the Risch syndrome, aortoiliac occlusion. So here, the fact that the pain is actually in the calf and not in the buttock area is very unusual for spinal stenosis. And so has me going to the PAD hypothesis. But we have to then say, wait, I know there's peripheral arterial disease. I suspect there's peripheral arterial disease. But what you're saying is you're worrying that the most common cause, atherosclerotic peripheral arterial disease, would be very unusual in a young person. And so that prompts investigation for the nature of what that peripheral arterial disease is, if it's there. So I think that's where we have to park that. I'm curious with the headache and the blurry vision, since that's not our immediate focus. I think we can spend less time on that because I imagine VJ's case is rich. I'll just ask you, is your instinct to say that that the blurry vision and the headache are actually from the same issue, that the headache and the blurry vision are caused by the same thing? Or do you have trouble merging them together or analyzing them discretely?
Yeah, I don't at this point think that we can safely say they're caused by the same process. I think temporally the headache being associated with the lower limb pain and the blurry vision being more of a constant, albeit progressive finding, have me thinking about them as separate processes for now, but that could change.
Very wise, very, very wise. I'll just make a short statement on that. And Mukund and I talked about a patient with blurry vision just last week. There are very few neurological causes of blurry vision. But the biggest piece of advice I have for you is when patients say blurry vision, they may mean something else. They mean that they have visual loss. So we have to be very careful to translate the patient's word from blurry vision to whether there's visual distortion versus visual loss. And the language that the patient uses may not capture the pathophysiology of the disease process. So a visual exam is key. And if the patient says they are blurry and your visual field confrontation is intact and their vision is intact, then you can confidently say that their vision is blurry. Blurry vision usually means there's something in the way of the light going from the outside and hitting the retina smoothly. And the things that can be in the way are a dense lens or a vitreous packed with hemorrhage, as an example. How can something neurologic impair the action of that light onto the retina? There's two possibilities. The first is the patient has pupillary abnormalities as part of an autonomic dysfunction and can't focus the light. And the second is that their optic nerve is bulging and swollen and distorting the contour of the retina. And so, Mukund, I'm right there with you. Those two hypotheses are such rare causes of blurry vision that they don't merit any consideration up front. But when you have a history of headaches with blurry vision, you might have to prioritize those hypotheses faster than you would otherwise. So said simply, you're right. Headaches and blurry vision is usually a non-neurological issue. And so we have to proceed with analyzing the blurry vision independently. But when blurry vision is neurologic, it often means a pupillary issue or papilledema. And so looking for those things earlier than you might have otherwise will probably be wise in this patient. All righty, VJ, wow, we're starting off very broad. I'm really curious what you have next for us.
So coming to the past medical history, patient was recently hospitalized for acute pancreatitis 1 month ago, treated conservatively, evaluation for which was negative for gallstones, calcium, triglycerides, or any family history or any pancreatic masses on the CT. No significant medications, family history, social history, none of that is any significant. Coming to the examination, on patient just walked into the OPD, so the BP was unrecordable. Then general physical examination, there was xanthelasma that was present. Apart from that, cardiac examination, muffled heart sounds. S1, S2 was well heard, there were no murmurs. Pulmonary examination, there are fine crackles that are present bilaterally. Abdomen, hepatosplenomegaly was present. Neurological examination, the cranial nerves were normal, there was no pain, whereas we did a fundoscopic exam that showed grade 2 papilledema. Coming to the extremity examination, so the upper limb, we could not feel any pulses. Lower limb, pulses were feeble. So the systolic BP on the lower limb was about 70. Coming to the initial labs, Hemoglobin is 8.6, baseline of about 10, MCV of 90, total count of 3,200 with normal differential, and a platelet of 1.4 lakhs. The range is between 1 to 1.5 baseline. Ferritin was 55. Triglyceride was mildly elevated at 128. Viral markers, which is HIV, HBsAg, and anti-HCV was negative. And the transthoracic echo showed moderate pericardial effusion with a normal biventricular function.
Mukund, we're discussing in New England Journal of CPC here, just to make it clear. This is an extremely complex and rare entity, and I just want to throw out a big shout out to A for scribing this case. It's not easy, but I think you're absolutely crushing it. I think, Mukund, we got all the data that Vijay said on the whiteboard, but I also caught that Vijay, that the brachial pulses were not basically were undetectable. The patient had such marked hypoperfusion of her arms that they could not measure a brachial pulse. And as A just wrote on the screen, that the patient has xanthelasmas. So, Mukund, I think this is really hard to actually make progress and digest unless you become systematic about it. So I'm curious if we just take a moment to focus on what conclusions we can draw from the vascular exam. And so pretend that all you have to analyze really to just make progress is the patient has no palpable pulses in any of her four limbs. How are you thinking that through?
Yeah, I think there are a couple of things here about both the extremity exam, the blood pressure, and the past medical history that all point to a specific thing for me, along with the age of the patient. And what I'm getting at is this person has a lot of fat in her system. Right? She has several signs pointing towards the accumulation of a lipoprotein yet unspecified in her system. So the reason I say that is she's a young person, but she has absent or feeble peripheral pulses, which is telling us that this is in fact a pathophysiology that's occurring inside the arterial wall. For some reason or another, blood is not able to make it through the arteries to these limbs. And this includes the upper limb, which in many people with classical peripheral arterial disease is not a common feature. So we know that if this is atherosclerosis, it's very severe. The fact that she has xanthelasmas is telling us that, so these are like fat-laden histiocytes that form in cases of severe hypertriglyceridemia or severe hypercholesterolemia. And the fact that she recently had acute pancreatitis at 30 without other predisposing factors, all pointing to a probably genetic cause of lipid overproduction or lipid hypometabolism.
Yeah, I think that's absolutely right. I think if we just take it a piecemeal, I think that the observations that you're pointing out big picture of this patient having a lipid profile on her skin without marked hypertriglyceridemia is the interesting disconnect. If you are encountering a patient who has no pulses in any of their limbs, you might say, well, where is the lesion? And I think it's whenever you have pulselessness in the upper body or lower body, you don't really know if it is in the aorta or in those limbs. But it would be very interesting to say, okay, where is the actual lesion? And there are essentially two possibilities here. The patient has a pan-aortic issue, and their entire aorta from top to bottom is affected, impairing perfusion of all four limbs. Or the patient has a diffuse vascular disease that's affecting every single medium artery. So if we sort of close our eyes and visualize where the lesion is, you might just see that the aorta is completely affected by this disease process, or that the disease process is actually just affecting every single medium-sized vessel. And so I think basically what progress we've made to understand this disease entity, and I'm by the way, I'm definitely still in the like understand what this disease is phase, recognizing a very powerful clue of the lipid disconnect. And so I think we have a prominent vascular component to this disease process. And the question remains, where is the lesion? Pan-aortic or diffuse vascular? How are you thinking about the papilledema, and how would you break that down?
Yeah, I guess to just keep it very general at this point, papilledema being a source of elevated intracranial pressure, I think we can just break this down into sources of elevated intracranial pressure. We can think of it as being increased brain parenchyma, for example, in the setting of cerebral edema, which I think in a vacuum without other information feels unlikely to me. We can think of it as being excess blood, which is also occupying the cerebral space, or we can think of it as being a problem with the drainage or production of cerebrospinal fluid.
Yeah.
I think of all of these things, what comes to mind for me right now is that perhaps there's an obstruction of vascular flow that's causing vascular or blood hypertension in the brain, but that is simultaneously causing reduced peripheral pulses.
Yeah. Superb. Yeah, I think that it's going to be really interesting to understand what this is and which compartment it falls in. Is it brain vascular or CSF? And I think that it's certainly hard, right, not to lean towards vascular, Mukund, because of the vascular hypotheses we have, with the idea being maybe this person has dural sinus thrombosis or a dural vascular disease that's connecting these dots. And I think whenever you hear headache and papilledema, you are often asking, okay, I need to take a look at the imaging. I need to take a look at the brain. And often you have the desire to get an MRI, but realistically speaking, a CT is done much faster. And so I think we jump to a non-con CT scan very quickly, but I would advocate for, if you don't have MRI capability very quickly, a CT with contrast will allow you to exonerate and really evaluate for one of the morbid hypotheses here. It'll allow you to look for hydrocephalus. It'll allow you to look for a lesion large enough to cause a papilledema. But then the elephant in the room is, what about the vascular hypothesis you said? And a CT with delayed venous phase can really look for the venous sinus thrombosis. So if you are in a resource limited setting, or if you're a setting like I work in where it takes a few hours to get an MRI, a CT with contrast is infinitely better than the reflex non-con CT here. And so I think we talked about the vessels. We've talked about the brain. You've very eloquently articulated that dental edemas are foamy macrophages that soak up lipid. And I think you've pointed out that the patient doesn't have much lipid. So is this a macrophage problem, genetic or acquired, is really the inference that I think you're making, which I think is very, very wise. And that macrophage type problem certainly overlaps with the ferritin that we found and the cytopenias and the hepatosplenomegaly and the pericardial effusion. But I think practically speaking, what we're going to have to do is to try to make progress on where the vascular lesion is, what the cause of the elevated intracranial pressure is, at the same time keeping an eye on the pericardial effusion to see if it is in fact going to cause some consequences to the patient. I think sampling a pericardial effusion tends not to be as productive as sampling a pleural fluid or acidic fluid. So I probably would keep my hands off that for now. Of course, if the suspicion changes for a malignant issue, that calculus would change. But I imagine we'll be enlightened tremendously by vascular imaging for this person and brain imaging to really say, what is this disease entity and why is there that disconnect that you pointed out? All right, Vijay. By the way, we're still in aliquot number 2, Mukund, just to keep us oriented. So tell us more.
So I'll just, as the chat was alluding to, the ESR was elevated at 68, and the CRP, ESR was 98 and CRP was 56. As suspicion of vascular disease was high, because we are thinking in similar lines of a pan-aortic syndrome because the upper limb and lower limb was involved. So a CT was done that showed encasement of peri-aortic soft tissue, perirenal soft tissue, interlobular septal thickenings in the bilateral lung fields, and a moderate pericardial effusion, and some ill-defined masses in the pancreas and peritoneal nodularities. I'll just show the MRI images. Is my screen visible?
Yes.
Okay, so
Yeah.
this was the imaging that was there of the MRI that we got. We got a pan MRI done of the entire body as well. So this is the aorta that is there. This is the liver. So this is the peri-aortic soft tissue that is there. And here we can see a moderate pericardial effusion that is surrounding the heart. And we can see some septal lines that is present. So that is septal thickening. And we can see a huge liver and an enlarged spleen. So coming to the kidney, so this is the kidney and there is a perirenal soft tissue thickening that is there in bilateral kidneys. And coming to the MRI that showed a dural masses, like this is a dural fold, and there are masses that are formed in the dura, which is enhancing with contrast. And there is also meningeal enhancement and an empty cella syndrome, partial empty cella that was seen on the MRI with tortuosity of the optic nerve.
Vijay, it's incredible that you got to see this patient in real life. I can't imagine how intriguing that must be, and absolutely amazing.
This was a case that I got as a cross consult for the chest findings. So I
Wow.
was intrigued and I
Yeah,
just followed
thank
up.
you so much for doing that and for teaching us. Really, really appreciate it. Since you stopped sharing your screen, maybe can you share your screen again? And
I have a little more data that I have to give. So we did a bone map. Yeah. So because there was a pancytopenia, fair pancytopenia that was going on. So we went ahead with the bone marrow aspiration that showed a normocellular marrow with no atypical cells or eosinophilia and occasional hemophagocytosis. Further subsequent evaluation with an ANA, ANCA, antiphospholipid antibodies, IgG4 levels were normal. The biopsy from the perirenal soft tissue that was accessible was suggestive of non-specific inflammation with no atypical cells.
oh, very, very intriguing. And Mukund, this is a really, really tricky case, and obviously, like often in the hospital with many, many consultants. But it allows us to really understand some components of it and try to synthesize it together. And I'm really curious, like about the brain MRI findings when you see diseases in the dura, and you're just trying to enhance your own descriptive diseases in the dura. What do you know of that landscape?
Diseases in the dura.
Mhm.
I mean, I think in this case, it looks like a mass either arising from or associated with the dura. I think meningioma is one thing that comes
Yes.
to mind.
Excellent.
Yeah. So either I mean, of course, tissue would help. Either it is a meningioma or it is a manifestation of whatever else is causing all of these other soft tissue abnormalities. In this case, I would think of some sort of infiltrative process. I think the fact that we've pointed out these xanthelasmas before and the aortic the xanthelasmas, the brain findings have me thinking of a histiocytic disorder, but this is definitely not my realm of expertise as it is others in the CP space.
Yeah, I'm glad it's not your realm of expertise, because I don't have a realm of expertise. I just think that all that we really do is try to make as much progress as we can. And expertise is I'll be an expert in nothing the day I die, just by trying very, very hard to know everything. But I'm really proud of what you said. You didn't let this case dissuade you from the most common cause of a dural mass, which is meningioma, by far and away. I recently saw a chronic subdural hematoma mimic a meningioma. And so I would say that on my radar for a dural mass is to not overlook a meningioma or a soft tissue or a chronic subdural. And sorry for the noise. I would say that the world of the dura is broken up into two categories. It's a focal dural disease or a diffuse dural disease. And a diffuse dural disease is one essentially called pachymeningitis, and a focal dural disease is what Rita just saw us showcase to us. And it really is very, very interesting when you have the combination of the two, like we have here, because this patient didn't just have dural masses, he had extensive dural disease. And I think the word that you used of infiltrative is really, really powerful, because it's very, very plausible that somebody has something going on and has an incidental meningioma, which is so common that it might be noise. But it'd be very, very unusual for that incidental meningioma to cause elevated intracranial pressure, but also to be accompanied by evidence of distant dural disease. So I think the reason, really just based on the MRI, that you need to extend beyond thinking about a meningioma as the patient has dural thickening elsewhere. And that really brings in the two most common causes of the overlap between a dural mass and dural thickening. The dural thickening is a differential diagnosis that Aaron has taught us many times. Dural mass we're talking about today, but what causes both? And it really is predominantly infiltrative diseases, namely the histiocytic conditions and sarcoid. So I just really want to point out that the MRI alone is a very, very powerful signature of this disease entity. And I think that you're seeing that disease entity do its thing. It's infiltrating the aorta, it's infiltrating the kidney, it's infiltrating the brain, it's infiltrating, and it's doing so in a way that's very characteristic of a histiocytic disease. And so I think that that very suspicion that you had early on of the disconnect between the lipid profile and the exam findings wasn't just now an observation, it is now a hypothesis that has gained a tremendous amount of momentum. So I think it's probably very wise to think of the histiocytic diseases now very, very thoroughly and deeply. And so let's open up that book. What do you know about histiocytic diseases? How do you think you can make progress here? What does that landscape look like for you?
Yeah, I mean, to be honest, the amount I know about histiocytic disease is pretty minimal. I just come acquiring little bits and pieces, of course, of other VMRs. But as far as their pathophysiology, I mean, I think of them in the bucket of infiltrative diseases, in this case, infiltration by cells or histiocytes, tissue-resident macrophages. And as far as diagnosis, tissue.
Yeah, 100%. I think that for almost all histiocytic diseases, or really all of them, tissue is the issue. And the attempt to distinguish between them is often faulted by the fact that they can easily coexist. And at the same time, when you gain momentum towards them and start to think about them, you have to humbly recognize that they're associated with many other potentially more morbid things. So the three main histiocytic diseases are Langerhans cell histiocytosis. In adults, that is a disease that is centered around the lungs. Erdheim-Chester, which is a disease centered around bones, which I'll explain in a bit. And then Rosai-Dorfman disease, a disease centered around lymph nodes. So if you think LCH lungs, Erdheim-Chester disease bones, and Rosai-Dorfman disease lymph nodes, that's where the story begins for those three main ones. I'll emphasize that they can coexist and that they can be associated with a wide variety of secondary autoimmune diseases, but more morbidly malignancies, usually in the myeloid, i.e. macrophage lineage. So that's the angst that we should have before we start to say which one of these three things is it, not to be open to the possibility it could be a combo. And Kirtan on Academy VMR presented a case of 3. Patient had all 3 of them. And to make sure we're not missing an associated malignancy. So here we have a lung focus. As Vijay said, there was interseptal lobular thickening, but the characteristic features of Langerhans cell histiocytosis are actually cystic lesions with micronodules, which this patient does not have, reducing the probability of Langerhans cell histiocytosis. Of the adult type, this patient is young enough that she could certainly have a manifestation of a juvenile Langerhans cell histiocytosis, which would be in keeping with this manifestation. The absence of lymphadenopathy here really makes Rosai-Dorfman disease much less likely. The radiographic pattern that we are getting here is characteristic of Erdheim-Chester disease, with the aortic encasement, the perirenal infiltrate, and the pericardial effusion, all in keeping with that disease. But I just told you it's centered around the bones, and none of that mentions the bones. 99% of patients with Erdheim-Chester disease have sclerotic lesions in their legs. And a bone scan or technetium-based bone scan can be almost diagnostic and almost avoid biopsy in patients with Erdheim-Chester disease. So you might be wondering, wait, she didn't really have pain in her limbs. Well, that's where the label of, is the claudication just claudication? Or is the claudication that she has both a vascular issue and that she has underlying bony lesions? So I think the next steps are tissue. The question is what tissue to obtain. That becomes tricky. They got the best kind, which is the perirenal infiltrate. The aorta is hard to biopsy, maybe the skin. But I think what would help you make progress is if a bone scan either showed sclerotic lesions or had intense radiotracer uptake, specifically in the lower limbs. That would really gain a lot of momentum for Erdheim-Chester disease. But it would be up to the treating clinicians to start treating for it. It does without biopsy, but it does get complicated because ultimately what you're trying to do in these histiocytic diseases is you're trying to see, do they have the BRAF mutation or not? Because BRAF positivity puts you down a specific treatment algorithm that the patient can benefit from. And BRAF staining is a tissue-based entity. So if I were to summarize, I would say that you need to know 3 things about histiocytic diseases. The first is that there are 3 leading ones, that they are commonly, second is that they are associated with many other conditions like cancers and autoimmune diseases. And the third, just to know the home base for each of them. Langerhans cell histiocytosis in adults is a cystic disease of the lungs. Rosai-Dorsman disease is a lymph node disease. And Erdheim-Chester is a disease that almost always involves the bones of the lower limbs. Any thoughts or questions come up for you, Mukund, before we hear from Vijay what they did?
I think I have a lot of reading to do, but on a superficial level, that checks out.
Awesome.
They're linking for sure.
Awesome. All right, Vijay, tell us more.
So we were having something similar in our mind. We revisited the MRI. The MRI showed osteosclerosis in the clivus and in the vertebral bodies. And coming to the hormonal profile, the thyroid functions were normal. The cortisol was mildly reduced at 9. FSH was reduced. LH was reduced. The electrolytes were normal. CT angiography showed entire reduction in the flow of about 80% up till the level of L3. And below that, it is about 50 to 60%. So because the bone marrow and the perirenal soft tissue were negative, we went ahead and repeated a perirenal soft tissue biopsy. So that was positive for CD68 and negative for CD1A, with so that favoring Erdheim-Chester or histiocytic infiltration. And given the clinical syndrome, final diagnosis of Erdheim-Chester disease was made. Only thing was the BRAF mutation as of now was awaited. Just 2 days back, the patient came. So apparently the BRAF mutations came negative. However, the patient is not very affordable. We don't have the access to the dabrafenib or any rare drugs. So we have put her on cladribine. We'll be following up the patient to see how she's doing.
Vijay, I just wanted to thank you you are the pulmonary consultant for this patient, and the least of her problems was her pulmonary issues, and yet you made it such a rich and educational case. And at the end, you taught us to always ensure we're looking for a pituitary consequence of histiocytic diseases. And I would say Mukund, we're seeing so many potential emergencies, limb ischemia, tamponade, but I would say pituitary insufficiency, especially adrenal insufficiency, is really important to think about in these patients. I'm really curious, Mukund. I always feel a little bit bad when a mighty case is thrown upon you on your relatively a small number of these public discussions. But I think that the ability to pick up on the disconnect between the lipids profile and the skin was quite remarkable and really got you to the landscape of the final diagnosis very quickly. But I'm curious how this felt and what reflections you are on what reflections you have on doing this.
Yeah, I think all of these case discussions are for fun first and foremost for me. I always take a lot from them. And I think in real life, as it's true with CP solvers, you're never solving these cases alone. So I am grateful for all of the other people. I think the chat was very active. I tend to keep it closed to avoid distracting myself, but I got a lot of notifications. I think that's part of the beauty of this space, is that there's so many people thinking about what's going on at the same time. So happy to have served as a platform for all of the rest of you to have had fun as well, and look forward to doing more of these.
Yeah, I think that that sentiment is so powerful, and I would say that it is really counteracting the narrative that, like, oh, I'm a medical student, so I'm not worthy of discussing a case that is especially this complex. And I think you've proven the exact opposite. I think you held your own in a battle against a very rare and mighty disease, and one that is affecting literally every organ of the patient's body, which pushes you to have to analyze every component of basically medicine. You have to analyze the brain, you have to analyze the lungs, you have to analyze the heart, you have to analyze the kidneys, you have to analyze the pituitary, you have to analyze all that. That requires a lot of learning and a lot of schemas, but I think also pushes you to be like, well, what's the telling clue here? And the telling clue from the get-go was the disconnect that you pointed out so early. I actually had to slow that hypothesis down because I didn't want us to miss out on the learning that would come from just analyzing everything independently. But I was mighty proud when I saw you do that. Vijay, how did it feel for you going through this journey with this patient, and what teaching points do you want to emphasize?
So I think the major thing was suspecting it. Initially, we thought when the pulse was literally nothing and patient comes walking in. So that was very surprising when you have no pulse and the patient walks in. So then the major learning was to think broad. So like I had to just see up a lot of schemas to say, where is the problem? So all of this initially just the lung patchy interlobular septal thickening. So close was the xanthal asthma that initially was only for triglyceride disorders. But now because of this, like I've kept infiltration as a major key for xanthal asthma as well. So this was very fun to crack what is happening to the patient.
Yeah, and I think you did so mightily with tremendous efficiency and accuracy. And yeah, I think what Mukund was saying about xanthelasmas is lipids and macrophages. And so both those entities can be the source of dysfunction. All right, Julia, you have not the enviable task of trying to summarize all the learning in this case. I'm sure you're up for it. The mic is yours, my friend.
Thank you so much. I have to find the right words, to be honest, because I'm so impressed by Mukund, how you evaluate on the whole case. I'm really impressed, and I've learned so much, and I loved your approach. And you did not miss on any detail. That was really encouraging and really great. Thank you so much. So I'll try to be brief. Try to sum up what I've learned and maybe what we can keep in mind when we remember discussing this case. So we kind of focused on the low limb pain at first, and then we thought about causes where we kind of think about the main causes being hypoperfusion or musculoskeletal. And if we want to distinguish the two, we can think about position and timing. Ultrasound can help as well. So in hypoperfusion, that can be due to a clot, claudication, or vasculitis. And we should think in claudication about like vascular and neurogenic courses, which are vulnerable to movement. Neurogenic courses are kind of a slowly progressive form of cauda equina, and the symptoms are dynamic rather than like continuous symptoms. Also, the pain will increase with extension. When the pain does not fully resolve, then we should think about musculoskeletal courses of lower limb pain. Secondly, even though it was not our main focus, we thought about the blurry vision. And first, before we analyze the symptoms, we should definitely prove if blurry vision or rather visual loss. Usually it's non-neurologic. When we think about neurologic causes, that will be like papillary edema, like for example, a dense lens or a pupillary issue or papillary edema. When we find a pulsionist in the leg, we try to analyze where the lesion is. In our patient, it was either a panaortic lesion or a diffuse vascular disease. So that helped us narrow down our differential. And we got the great information of an MRI where papillary edema also was visible, and that has three main causes. It can be from the brain, it can be vascular or CSF. We saw also a dural mass that can be due to a meningoma or a chronic subdural bleeding. Interestingly, in our patient, we had the overlap symptoms of a dural mass and a dural thickening, and that helped us to narrow down to pretty much two courses, histiocytic disease or sarcoid. Mukund did not miss the interesting disconnect about the lipid profile we found in the labs and the missing hypertriglyceridemia. And that kind of led us to the conclusion that there has to be a macrophages problem. The pericardial perfusion and ferritin kind of supported this hypothesis. Lastly, Rabih brilliantly teaches us, and I've never heard anyone breaking down histiocytic diseases, so I understood it. So thank you so much. We should definitely think about tissue is the issue. So do we find BRAF positivity, because that kind of leads to another therapeutic issue. But overall, we should know that we have like three different or main diseases. So it can be Langerhans cell histiocytosis, Erdheim-Chester, or Rosa-Dorfman disease, and the clinics can help us to kind of differentiate. We should keep in mind that then they can coexist, and if we find histiocytic disease, we should check if there's any autoimmune disease or cancer in the background. Lastly, Vijay reminded us there can also be pituitary consequences of histiocytic diseases. So check for these ones. That was a lot. Thank you for keeping with me until the end. And I'm so grateful and have many topics to dive in. I'm excited for that. So thank you for this amazing case.
Oh my God, Julia, you're probably going to be busy for years reading about the case yesterday and case today, summarizing the teaching points. But the summary was absolutely superb. And as you can tell from the whiteboard, it's so organized. And I think the way you organized it in your mind to share with us was really impressive. So I hope you all get to dive in more and understand all these things more. I know I certainly will, and hope to see you for yet another experience tomorrow. We have Jas, who's presenting a case, which just like Vijay is always a treat. So I hope you can make it. All right, y'all. Have a great rest of your day. Bye.